So after Rajulsa's talk, excellent talk and videos, ROCK inhibitors is going to be a very boring talk and it's going to be agonizing, but I'll try to reduce your agony. I'll try to be as quick and painless as possible. So my first slide states something very interesting, that none of the existing anti-glaucoma drugs, they have an effect on the conventional aqueous humor outflow pathway. So that is very, very important, that none of the existing drugs, they act on the conventional pathway, but ROCK inhibitors do, because they lower the IOP by increasing the conventional aqueous outflow through the trabecular meshwork and the Schlemm canal. So that is a very, very interesting fact. So in this talk, I'll quickly cover 10 points, which I hope is going to convince you to start ROCK inhibitors if you have not already started them. Number one is the IOP factor. Now, the ROCK inhibitors decrease the aqueous humor outflow resistance. How do they do it? They do it by altering the cellular components of the trabecular meshwork and the Schlemm canal. So they increase certain things, like they increase the cell permeability and the cell relaxation, and they decrease certain things. For example, the ECM rigidity, the ECM cross-linking, the actin cross-linking, etc. Now, is this proven in terms of studies? And the answer to that is yes. This particular study, published way back in 2016, showed, with the help of OCT as well as speckle variants, that when you use ROCK inhibitors, there is an expansion of the Schlemm canal, and the speckle variants image showed that not only is there an expansion of the Schlemm canal, there is an expansion of the scleral vessels also. So two things are happening. A, there is an effect on the proximal net pathway, that is the trabecular meshwork and the Schlemm canal. And B, there is an effect in the distal pathway, that is the intrascleral and the episcleral vessels. What that translates into is that there is an IOP drop which is significant, and it is sustained, and it is effective over a wide range of glaucomas and ocular hypertensives. So it is effective in ocular hypertension, PUAG, NTG, PACG, as well as secondary glaucoma, and the percentage of IOP drop is fairly good at 15 to 20%. So the first take home is that ROCK inhibitors are effective in all types of glaucomas. Second point, the effect on episcleral venous pressure. Now the ROCK inhibitors, they enhance the aqueous outflow in the episcleral vessels. How do they do it? They relax the smooth muscles in the episcleral veins, and they cause a dilatation of the aqueous column and the episcleral veins. So this was a hemoglobin video imaging. This was a head-to-head between latanoprost and ROCK inhibitors. And what they showed is that if you look at the aqueous column, there is no dilatation with the use of latanoprost, but there is a significant dilatation when you use ROCK inhibitors. So it is effective in those glaucomas where episcleral venous pressure is an issue. So the take home too is ROCK inhibitors can be used as a treatment modality in glaucomas with raised episcleral venous pressure. For example, Sturge-Weber syndrome, idiopathic raised episcleral venous pressure, and Graves' disease. Number 3, the effect on ocular blood flow. Now, there are certain studies which have shown that ROCK inhibitors increase the blood flow around the optic nerve head. This has also been shown in human studies, a head-to-head with brimonidine, as in this study published in 2018, which showed that ROCK inhibitors increase the peripapillary vessel density on OCT angio, while brimonidine does not. So the take-home 3 is it increases optic nerve head blood flow, so it can be effective in NTG cases. Now let's come to neuroprotection. Now, how do ROCK inhibitors affect neuroprotection? So what do? A, they create a growth-promoting milieu. B, they increase vasodilatation around the optic nerve head, and thus they remove the pro-apoptotic factors and inhibitory molecules, as a result of which there is neurite outgrowth and there is axonal regeneration. Now, what is very interesting is that it is effective not only in ocular tissues, but ROCK inhibitors has been extensively studied in Alzheimer's and dementia, and they have been proven to be useful. Now coming back to ocular tissues, what has been seen is if you use the optic nerve head crush model, for example, you damage the optic nerve and then you apply placebo in one group and ROCK inhibitors to the other group. In the placebo group, there is hardly any neuronal regeneration. Whereas if you look at the use of ROCK inhibitors like Fasudil, there is a large amount of neuronal regeneration, and thus the take home 4 is that ROCK inhibitors can be used for neuroprotection. Take home 5 is very, very important. Effect of ROCK inhibitors on the cornea. Now they do a lot of things on the cornea. They increase the cell proliferation and the cell adhesion, and they decrease the apoptosis. As a result of which, what happens? Number one, it can be used in endothelial wound healing, in corneal clearing post-DMEC, and in post-cataract surgery cases. I'll quickly discuss some examples. So this particular study, which was published in 2016, in this case, half of the cornea was mechanically scraped. And then one group placebo was used, in the other group ROCK inhibitors were used. And what they found was that there was a gross decrease in corneal thickness. That is, the corneal edema was much less in the ROCK inhibitor group, and the topographic pictures were much, much better. So definitely ROCK inhibitors have an effect on corneal endothelial wound healing. So does it translate to an effect on cataract surgery cases? Yes. This particular study published in 2021, it showed that if you use ROCK inhibitors twice daily for 6 months post cataract surgery, what you find is that there is less increase in corneal thickness, that is less edema, 1% compared to around 6% in the control group, and there is less mean endothelial cell density loss, around 4.5% compared to 14%. Now this and a large number of examples clearly show that there is a very good effect on endothelial wound healing. So this particular case, where a 71-year-old male patient had an iris cyst along with cataract, underwent iris cyst dissection, and you can see the corneal status post-surgery. And this is 6 months post-use of ROCK inhibitors. So there is an amazing transformation in these cases. And this particular study was really an eye-opener. In this case, they took 11 cases of PBK, and they took some human corneal endothelial cells, and they took it from a donor and they cultured it with ROCK inhibitors, and then they injected it into the PBK eyes. And they say a picture speaks 1,000 words. So you can see in all these 11 cases, even after 2 years of follow-up, you can see the clear corneas on the right side. So there is definitely an effect of ROCK inhibitors on the cornea. So take home 5 is that they can be used in PBK cases, post-DMEC, post-PK, post-cataract, post-trauma, etc. Number 6, like we were kind of mentioning about SLT. So what has been found is that ROCK inhibitors are an outcome marker for SLT and micropulse. What that means is if a patient responds to ROCK inhibitors, they will respond to SLT and micropulse, which is the take home 6. Take home 7, do they have any correlation with trabeculotomy? Yes, ROCK inhibitors can be used as a trabeculotomy outcome markers. Patients who respond to ROCK inhibitors will respond better to surgeries like trabeculotomy or surgeries like GAT. Do they have an effect on trabeculectomy? The answer is again yes, because ROCK inhibitors decrease fibrosis. This particular study, where ROCK inhibitors were used twice daily for 4 weeks after TRAB, what they found was that IOP was lower in the ripasudal group, bleb scores, that is well-formed diffuse blebs, were higher in the ripasudal group, and adhesion scores, that is how much the flaps were adherent, the lesser score means better, so less adhesion scores were seen. So the take home 7 is short-term use of ROCK inhibitors in pre-op cases and twice daily for 4 weeks in post-op cases increase the success rate of TRAB. Another very interesting thing, ROCK inhibitors as anti-inflammatory agents. In this study, uveitis was induced in the foot pad of rats, and they used ROCK inhibitors, and they found that ROCK inhibitors significantly reduce the infiltrating cells, and protein exudation in the aqueous humor, reduces infiltrating cells in the iris and ciliary body, and reduces adherent leukocytes in the retinal vessels. So if you look at this very interesting chart, you see that there's a huge response of uveitic glaucoma cases to ROCK inhibitors, of exfoliative glaucoma cases, and of steroid-induced glaucoma to ROCK inhibitors, which is take home 8, effective in uveitic glaucoma, PXF glaucoma, and steroid-induced glaucoma. In retinal disorders, it has been seen that ROCK inhibitors increase the ocular blood flow and reduce non-perfusion areas, and it also reduces foveal thickness in DME. So it is effective in glaucomas with retinal vascular disorders, and again this has been discussed because it's a new drug. It is an addition to the armamentarium in case of maximal medical therapy. So I would end with this one slide, and I want you to remember this, what the authors had concluded in this study published in 2020. What they had said is, ripasudil acts by increasing the conventional aqueous humor outflow by changing the status of the trabecular meshwork and the endothelial cells of the Schlemm canal. So ripasudil treatment should be started during an early stage of glaucoma before irreversible damage to the components of the TM occurs. So probably you should start using ripasudil early rather than late. So I rest my case. Thank you.
Thank you, Dr. Arjit. I think it was very extensive coverage of ripasudil and ROCK inhibitors as a whole. So, Sumit sir, what have been your experience? Because now I think 5 years ROCK inhibitors are there in Indian market. So how has been your experience?
To be very frank, as what Saurabh said, to be used early, most of us don't use it. If I take the hands up,
That is primarily because of the side effects. Primarily because of the side effects.
but not all patients go for the redness, not all patients go for the cornea anything problem.
In a failing trap or failed trap, if I decide not to do another procedure, I have started using netasudil or ripasudil as a first line.
First line.
And yeah, and also in many cases, after a prostaglandin, I have started and seen very good result, like netasudil or ripasudil. Netasudil at 6 p.m. and latanoprost or lumigan. Redness is high. Sometimes the redness is a problem, but in not all eyes.
But netasudil maybe started early, but not the ripasudil, I hope.
Why?
Which one is the preferred?
For me, both are almost same. Preference, efficacy wise, I don't find much of a difference. Netasudil is usually efficacious. Sometimes more efficacious than ripasudil.
Yes, if we use the netasudil with the latanoprost, it works better than other prostaglandins. This is my preference.
Netasudil as?
Latanoprost.
Yes, that's what I'm telling.
Better
We
than
start
use
the
netasudil with
patient.
other one.
Start the patient with latanoprost, then you can add a netasudil.
That's right.
Arjit, are you using ROCK inhibitors early in your practice?
No, not as of now. Even though I was playing devil's advocate here, I'm not using it.
Why is that the reason?
Because I have a kind of pretty known track record of whatever, be it a latanoprost or a bimatoprost. I'm still a bit unsure as to the percentage of IOP reduction that I'm going to achieve. So as a first line, I'm a little bit hesitant to use it.
Vidya.
In a partially functioning trabeculectomy, you give twice daily ripasudil, it works pretty well.
Correct. Right. So probably take home, we are getting confused. Deepanjana is doing advocating MIGs or Deepanjana is advocating drugs or trap. Everybody is going to be very confused.
After failed trap,
After failed trap.
he's telling after failed trap, he's using it the first line agent, not for normal cases.
Right. Ma'am. No, ma'am. I mean, they haven't replied back to that query, but ideally we should stop it. I mean, if you're having reticular edema, it's not going to go. So there was a question that there is a reticular corneal edema. should we continue the drug or should we stop it? I mean, like, so there was a video by Dr. Uday Devgan, cataract coach, where they presented a very beautiful case where they had reticular edema. But what was mentioned is that we waited for some months and then the edema subsided. So we were just wondering whether they continued the drug or they stopped the drug. Yes, ma'am, please.
It was very beautiful presentations. I have an interesting question. If the drug works in so many ways,
Correct.
so why the IOP is not getting reduced for everybody
Right.
or in that way?
Right. It's very similar to why SLT is working in 80% and we are not using, or MIGS is working in. So initially, I have no clue as to the reason.
It works in every way.
True, ma'am. True, ideally.
So treatment naive patients, anything and everything will work, you know.
Try Repasudil or Retasudil is as second line, the reduction is fantastic. You can give a trial. If they supply you with medicine, that is okay, but the ठीक है.
Can
दवा इतना महंगा भी नहीं है, यूज कर सकते हैं.
the response of ROCK inhibitors in pediatric age group, 8 years, 10-year-olds, I have found that they respond much better than adults, and they don't even have redness that much.
And also the Sturge-Weber syndromes where the Netasodil is observed.
Yeah, that is another group of people, like another group of eyes where there is
Mike, Dada.
increased episteral venous pressure, or there are many eyes where we see that there could be idiopathic high EVP.
Thank you.
That may not be Sturge-Weber, but there could be idiopathic high EVP.
And uveitic glaucoma. This is for Devashish sir.